This is the Cardio Ohio podcast, a presentation of the Ohio chapter of the American College of Cardiology. This is Canny Graywall, president of the Ohio chapter and host for today's discussion. Further information about this podcast, including speaker biographies as well as references, are available at ohioacc.org. The podcast will also be available for download wherever you access podcasts, and we encourage you to subscribe to receive updates on future sessions. And now for today's discussion. Welcome back to the Cardio Ohio podcast. This is Canny Graywall, your co-host today. I'd also like to welcome again my reliable co-host, Ben Allencherry from the North Coast of Ohio. Ben, how are you doing?
I'm doing great today, Canny. I'm excited to delve into the world of intervention and learn more about optimal DAPT practices.
Yeah, absolutely. And in that regard, we are very fortunate to welcome Dr. Jagdish Kanagavi. Now, he's currently the assistant professor of internal medicine at the University of Cincinnati College of Medicine. He practices at university there as well. Jagdish, welcome. And for our first question, we just thought you could kind of introduce yourself and talk a little about like what personally led you to your career in interventional cardiology and also how you arrived in Cincinnati.
Good evening, Canny. Thank you so much for inviting me to be part of this Cardio Ohio podcast. In terms of my career goals of being an interventional cardiologist, I think a lot of credit goes to my mentors at Rush University as well as Cook County Hospital where I trained. Both those hospitals were very geared towards interventional cardiology. And yeah, I think just a natural gravitation towards the field.
And Jagdish, your reputation and your impact on your fellows at Cincinnati precedes you because several of them recommended you, and we're excited to hear what you have to say.
Thanks so much, Ben. Look forward to it.
So Jagdish, Ben and I, we're both non-invasive cardiologists. We're all of us are busy clinicians. You yourself see a lot of patients, both in the hospital and the clinic. And of course, you're very busy in the interventional lab. Obviously, a majority of patients who have coronary disease, even those who require intervention, ultimately are followed by general cardiologists. For our podcast today, we have an audience of general cardiologists. We have subspecialists in all the various areas. We have a lot of advanced practice practitioners in cardiology and fellows in training as well. So pretty broad audience, most of whom are not interventional specialists. So we really appreciate your perspective today on what is a very, very practical topic that I think all of us in every area of cardiology have to address every day, which is the type, the duration of antiplatelet therapy after cardiac intervention and how to address specific situations when it may need to be discontinued, modified, or extended. We wanted to start by just asking you, in routine patients who have percutaneous intervention, whether it's part of an acute coronary syndrome or simply somebody with chronic stable disease, what are the key factors that help you decide the initial antiplatelet therapy in terms of when you might pick a more potent agent versus the more traditional route of using clopidogrel and aspirin?
And I think it's a very important primary question to answer. And I think in the last 10 years, there has been so much of very good trial data, which has actually now made us make what used to be expert opinion decisions with a lot more data per se. And I kind of elaborate that as we discuss this other subtopics in this. But this question of which initial oral P2Y12 inhibitor to choose has some clarity, at least when it comes to if we look at the clinical scenario where we end up choosing it. So elective PCI for a stable ischemic heart disease patient, the strongest data or the data exists mostly for clopidogrel. And if we have an acute coronary syndrome patient, then we have all three of our oral and P2Y12 inhibitors, which is clopidogrel, prasugrel, and ticagrelor. And the recent data definitely, which is what all the guidelines, both European and American guidelines, kind of give clear indication is to choose ticagrelor or prasugrel with some caveats to prasugrel based on clinical situations over clopidogrel. So I think first distinction to make is the PCOS done for stable ischemic heart disease versus ACS. And if it's stable ischemic heart disease, use clopidogrel. if it is acute coronary syndrome, preference for ticagrelor and prasugrel over clopidogrel, more so ticagrelor because it has less restrictions. To give you an example, like if you had a patient with prior stroke, you're restricted from not being able to use prasugrel. If you have a patient who's got a GFR, which is low, or if you have a patient who is low body weight, so there's certain restrictions which would come with prasugrel. But nonetheless, there is also some good data saying that prasugrel for the right patient does equally good. So basically, they have much more ischemic benefit, less stent thrombosis, less non-stent related ischemic events as well.
And I think you bring up a good point, Jagdish, about the duration. So just for the fellows and trainees listening, the 2021 guidelines that are endorsed by ACC, AHA, and SCI kind of have that same flow chart you're talking about, immediate distinction between stable ischemic heart disease and acute coronary syndrome. And you briefly touched on the choice of antiplatelet therapy. Now we kind of want to talk about the duration. When you're deciding this, first, we always balance bleeding risk, et cetera. And in all the trials, they use different sort of gauges of bleeding risk. What are you actually using in your practice, regardless if it's ACS or stable ischemic heart disease? Are you using a particular risk score, or are you taking just a general gestalt on history and some of the patient's characteristics? How are you deciding the bleeding risk in the patients you treat clinically?
I think that's an excellent question, Ben. I think generally it's pretty obvious sometimes with the patient clinical history or certain findings, which kind of give us an idea. But recently, we've had some amount of data which supports this, especially with the Bleeding Research Council or BARC. We have now some data to kind of classify patients into high bleeding risk. Having said that, in routine clinical use, it's quite an extensive list. It's almost like a gray score, right? Which we use to stratify patients into NSTEMIs to who needs early invasive management. Similarly, this high bleeding risk classification has almost like 20 clinical parameters which go into it to kind of give you. So the general concept I'll tell you basically is if you have one major bleeding risk criteria or two minor bleeding risk criteria, and all of these criteria which go into it are clinical and make very intuitive sense, which is basically like, say, somebody had a history of intracranial hemorrhage in the last 6 months, or history of stroke in the last 6 months, or history of thrombocytopenia. All these would be like considered major risk factors. So if you had one major criteria, you would consider that as a high bleeding risk patient. So I think by clinical gestalt, when you kind of evaluate the patient, you already have a pretty good sense. But if you want to objectively quantify it, there are tools like what I was saying, based on some of the data sets, mostly of some of which were developed in Europe. There's also something called a precision DAPT score, uses 5 clinical factors, which again, developed in Europe, used pretty commonly over there. Routine clinical practice from my side, I would say most often it is knowing this in the background, knowing all of these risk factors, and looking at the patient when you're looking at all the clinical risk factors. If you see obvious red flags, which like say you know that the patient has like a cancer which is going to be operated on within or need to be operated on in a month or a couple of months, then by definition, it's one of the major criteria for high bleeding risk. So not necessarily using these tools, but being aware of all of these risk factors and kind of thinking about it. And this is what all those recent data has shown us, that being able to recognize and having the options as with the newer generation stents of shortening the duration of TAP makes you more aware of, okay, this is how I'm going to define a high bleeding in this patient.
Yeah, I think that's helpful. We'll also include in the show notes that precise depth score, and encourage everyone to kind of play around with it. You can kind of see how the high risk bleeding can change with little parameters such as hemoglobin change, et cetera.
Yep.
And so that's good to know that that's more of a gestalt thing, especially as you get more used to it. Just one more question to piggyback before we change our topic. There are some times where you may want to extend the duration of dual antiplatelet therapy after an intervention. stent characteristics, other disease, the placement of the stent, if it was well opposed, et cetera. Can you just give us an example of a recent patient where you thought maybe we'll extend therapy of dual antiplatelet therapy after an intervention?
Yeah, I think one of the very easy things to kind of make sense of this is, I think the patients whom we consider a longer duration of dual antiplatelet therapy is very clearly low bleeding risk patient with a high ischemic risk. And one of the commonest examples I can tell you is, say somebody you did a left main PCI on, and let's see, for whatever the reason, the patient didn't go for bypass graft surgery, ended up getting a left main PCI, and you have so much myocardium at risk that, and if they are truly low bleeding risk, you could define that with you could use ADAPT trial data for that. If you have a favorable ADAPT score, which is greater than or equal to 2, then that's a patient whom you would consider definitely extending an antiplatelet beyond 12 months. Another example I could give is somebody, if you did a saphenous vein graft intervention, if they happen to be a younger patient, and otherwise, even if they're not younger, but a low bleeding risk profile, yes, that's another patient whom you know that you're going to have high ischemic events just by the nature of how saphenous vein graft intervention results are. We still know that these patients will have more events, per se, just from get-go. Those are a couple of things which I think I can easily think of, which I would continue long term.
And one question just to clarify, Jagdish, when you talk about extending therapy, I know in the DAP trial, they use dual therapy, but I also know there have been trials of Plavix, like monotherapy in patients beyond 12 months. Is there any consensus now on what patient may benefit from which of those, or is it also still kind of tailored to their characteristics?
I think the dual antiplatelet therapy has more data from trials. But having said that, the way I would think about it is, what all the shorter duration trials have shown is that this more potent, especially ticagrelor and prasugrel, single antiplatelet therapy is equally good compared to adding aspirin on top of it. So you could make a case that, say, beyond a year, if you wanted to consider a single antiplatelet therapy, you could drop the aspirin instead of dropping the P2Y12 inhibitor. And with the data we have, it makes intuitive sense to continue a single antiplatelet, which could be Plavix probably, rather than prasugrel or ticagrelor, because they're so potent and you don't really have that much of ischemic burden 1 year out. So I would say it makes a lot of clinical sense, say, if you wanted to give somebody a protection with the Plavix. The only clinical reason not to do it is, obviously, patients tend to have reasons to stop Plavix for, say, like a dental procedure or minor surgery or something like that. And those are the things, again, where clinically you have to be vigilant of that, because if you're extending the duration of the antiplatelets, you will continue to have multiple visits or phone calls or clinical questions being raised about, okay, what do we do with your colonoscopy now? What are you going to do with your dental extraction? So I think that is the only caveat about when you consider single antiplatelet longer term.
And Jagdish, you bring up a great point. And this is something that we as fellows deal with a lot, especially as pre-op testing. We sometimes see these patients on Plavix monotherapy, and they either had it stopped and had an ischemic event pre-colonoscopy or something. This is not meant to be a trap question or anything, but just a clinical vignette for you. If you have a patient like that who had an event greater than 1 year ago and they're on Plavix monotherapy, what do you suggest that patient to do? Do they switch to aspirin and they do the procedure on aspirin, or do you have a conversation with the proceduralist that consider doing this on Plavix? How does that actually work out in the real world?
I think the data for safely interrupting an antiplatelet is pretty strong after even like 3 to 6 months. Although there is some data, actually, like research papers, which actually quantify the amount of bleeding risk with antiplatelets with different kinds of surgeries. What I find in clinical practice is surgeons prefer to operate on aspirin and not on any other antiplatelet. So I would, if the patient has not had PCI or an ischemic event in the last 3 to 6 months, I would just switch them to aspirin to just help them get through the surgery for that amount of time.
And since we're already talking a little bit about unexpected discontinuation of therapy, I think the other topic, we certainly want your input on is the patients who come in with more serious, bleeding events early in the post-PCI course. Maybe they just have an upper GI bleed, or maybe they have a CNS event and they need urgent neurosurgery. I know the risk is not continuous, right? From the time of the intervention, it does drop off after certain periods of time. So, Jagdish, do you feel like you have a better sense of the time frame when the risk starts to become acceptable, say both ACS or non-ACS, if the patient is not coming in a period of months afterwards and requiring, major surgery that's unexpected?
Yeah, I think Ken, that's a very important question to answer actually, and I'll kind of preface it this way: I have not used a bare metal stent in 4 years, since I've started working as an attending. And the reason for that, I still remember using a couple of bare metal stents probably through my entire interventional year. And that reason used to be because of you would use a bare metal stent in a patient who has a surgery coming up or is at a higher bleeding risk. The reason that has happened where we are using DES on pretty much everybody is we know that DES is much better. That's kind of very well proven. And now we have the options of getting patients through with bridging therapies with IV cangrelor. That has been such a big help to interventional cardiologists because we always encounter these patients who say have some kind of surgery coming up and then they get a pre-op, and then we find a critical lesion and we need to optimize those patients for their surgery, and we then put a stent in and then they need to go for the surgery. So the new expert consensus opinion is that if you're going to operate on less than 3 months, then there is a lot of favor in bridging those patients with IV antiplatelets. Now with cangrelor, there's pretty much a very good algorithm for it, which most institutions use. We certainly do. It's a low dose cangrelor drip, which you kind of start on the day when you interrupt the antiplatelet. So say if it is Plavix, you would stop the Plavix 5 days prior to the planned procedure, and start the inpatient on IV cangrelor at 0.75. And you could even prepone the surgery, say by Ben was asking about looking at platelet reactivity assays. Some of our surgeons do that. They will try to see if the Plavix is still active. Once the P2Y12 levels go up, they will see that the platelet activity has gone down, and they may even operate a little sooner. But at least you have this opportunity where you can bridge the patient. So the data is definitely where most people are now thinking of is less than 3 months after DES, consider bridging. After 3 months, with all of the shorter DAP trials, now actually even the guidelines say you can drop the second antiplatelet. Say in the case of a stable ischemic heart disease patient, what a pre-op patient would have been, you can stop after 3 months this antiplatelet and just continue aspirin. So that's been my practice, where I have a cutoff 3 months for bridging. Until after that, just basically have them stop the antiplatelet as minimum as they can.
And that 3-month window would be relevant for both ACS or non-ACS is something we
So ACS, yes, that's the only distinction. ACS, unless the surgery is critical, I would probably extend the bridging till 6 months, especially if it is a high ischemic burden patient or a high ischemic risk patient. So you would probably stretch bridging until 6 months.
Yeah, I think that's something us non-interventionalists are less familiar with, but it sounds like it's in the consensus in that population. In our last 5 or 10 minutes, we just wanted to touch on really 2 brief topics. The first is, concomitant OACs, because obviously this is a very common clinical dilemma. The patient who has atrial fibrillation or maybe a history of pulmonary embolic disease and now needs PCI. I think that's evolved as well in the last few years to kind of more of a standard approach. But we just wanted to get your thoughts about, the patient who clearly has an indication for an OAC. How do we approach both the peri-procedural antiplatelet therapy, and then how do we approach the post-PCI type and duration of therapy?
I think the way you split it very nicely, actually, what to do peri-procedural as well as long term. I'll first address the peri-procedural part of it. I think that we are basically talking about a patient who is on oral anticoagulation for AFib, let's say, and now needs cath and subsequently a PCI. So when do we hold his Xarelto or when do you hold his apixaban? So the consensus is 24 to 48 hours. Why do I give that window? So if you're convinced that you're going to do a good radial access, radial PCI, then you could get away with holding apixaban for a day. But sometimes 10% of the time you have to switch to femoral, and the data for that is around 48 hours. So my standard practice has been 48 hours. And the similar things with INR targets for Coumadin, the Sky consensus for that for best practices is INR of less than 1.8. Again, a lot of us say if we are doing it for somebody who, say, has a mechanical valve and some Coumadin, and we are trying to kind of not interrupt them too much and also add low NOx on top, then we will try to work as much radial as we can and try to keep them on the lower target around. So I will do a case with, say, mechanical aortic valve with an INR of 2 rather than a 1.8. So there is some amount of leniency. And if we go femoral, we also try to use closure devices so that the risk of bleeding is a little less. So that's one aspect of it as to how, and we resume basically the oral anticoagulant the same night most of the times, or the next day morning, as long as there is no access site bleeding and there is good hemostasis. So that's the peri-procedural part of how we are doing the anticoagulation part. And the next question is, what antiplatelet do you add? Now this patient has gotten a stent during that cath. What antiplatelet do you add? So the consensus, almost a consensus, is to use Plavix over the more potent, because you already have an anticoagulant, which is going to reduce your ischemic risk of stent thrombosis or another ischemic event, de novo ischemic event. So you really need an antiplatelet to just get you good epithelialization of the stent and not give you more additional reduction in the ischemic burden. And triple therapy is pretty much now confined only to acute coronary syndrome. And even in there, it is probably most of us do 1 week. If you have a really high ischemic burden patient, and you say, again, the same example, like a left main PCI in an ACS or a saphenous vein graft PCI in an ACS, I would use aspirin for a month, or not longer than that. So I would use apixaban, Plavix, and an aspirin from anywhere from a week to a month. And on some patients who are stable ischemic heart disease, and it's a type A lesion and a straightforward non-bifurcation PCI, the only aspirin they get is on the day of the procedure, the 325 loading dose on the day of when the stent goes in, and they get the apixaban in the night. They go with apixaban and Plavix.
Yeah, Jagdish, that's helpful to hear that some of those stent characteristics, location, extent of other disease helps dictate not only the duration, but also the intensity of antiplatelet and anticoagulant therapy. To bring up just a point about this now, as fellows, we sometimes see platelet reactivity testing, and you talked about the commercial verified now system. Just from your practice, there's not uniform usage of this, especially after giving an antiplatelet, to see how the patient would respond from a platelet reactivity point of view. When are you actually using this? And you can just give clinical situations when you're using platelet reactivity testing in your daily practice.
I think, Ben, I've seen a lot less use of it compared to, say, 6 years ago. But definitely one of the easiest examples is patients who, say, are waiting for coronary artery bypass graft surgery in the cardiovascular ICU. And unfortunately, they had an ACS event, so they got loaded with Brilinta, Plavix, one of those two meds in the ER. And we found that they have surgical anatomy and they didn't get PCI and waiting for surgery. That's when I think you're trying to balance, not having to have them sitting in the unit for 5 days. And especially with Plavix, there is variability of response. You will see some patients that platelet reactivity assay numbers go up very nicely within 2 to 3 days. So the surgeons don't have to wait for the recommended 5 to 7 days. So that's one example of where I'd use. In terms of efficacy testing, I don't normally do it on anybody because I know that some of the patients would, because Plavix being pro-drug, sometimes you may not see the assay and there is biological variability about how effective medication is, but clinically it has not borne out. So I really don't use it in those to check efficacy in any patient at all.
Got it. Yeah, that it's a bit complex of when we see it in real practice. And I know there's a recent publication of a small trial with a ticagrelor reversal agent, so it might even be used less. But that's very helpful. Thanks.
Well, Jagdish, we're coming up against our time, but I really think we covered a lot of very practical topics. I've been taking some notes, just listening to all your insight, and it really sounds like the theme now is, a patient-centered approach, that we're not just following formulas for duration or type of drug, but that we're really focusing on each patient, both for the initial choice of the agent, but also for duration, whether we decide to extend it in the higher risk patients or shorten it for the higher bleeding risk patients. And am I correct to say also that you're saying judicious use of bleeding scores combined with, your clinical gestalt is the best approach to assess risk? And, you've given us some advice about interrupting therapy as well, either because they have concomitant OACs or because patients who need to undergo interruption for surgery. But I really think that it's been very insightful. Do you have any other final wrap-up comments or any other related topics you wanted to address before we wrap things up?
Kenny, I think you summarized it well. What I would say is basically we've gone from the first generation stents where everybody got standard 12 months of dual antiplatelet therapy towards getting a lot more insight to help us get through clinical situations. And you're absolutely right. Our patient population has continued to become more and more prone to bleeding. Like pretty much some data sets say 60% of the patients actually have some or the other clinical factor which make them a high bleeding risk patient who undergo PCI. So that what used to be an expert opinion has data to substantiate it, and obviously try to be mindful of both trying to address the ischemic burden as well as address the bleeding risk. And that has truly come about because of the second generation stents and the newer bioresorbable polymers, all of these stent technologies where the stent strut thickness is a lot more smaller than before, has allowed trialists to try shorter duration of therapy and prove the safety as well as efficacy. So I think it's a very exciting field.
Yeah, well, we definitely look forward to you continuing to educate us, both in this format and also throughout our other educational activities as this data keeps evolving. I do want to put a quick plug in for our annual meeting, which will be held on October 22nd here in Columbus. We're going to actually have a very nice discussion on the new ACC/HA guidelines on revascularization in terms of both the surgical and interventional perspective, with a bit of a debate between some excellent experts. So I do hope all of our listeners have a chance to register for that meeting. It's open now, the registration, and it's going to be our first live meeting in 3 years. So I really look forward to interacting with everyone, including you, Jagdish. I know you just were elected to the State of Ohio board, so congratulations on that. And so thank you, Ben, for your insight, and thanks, Jagdish. We look forward to getting together again in the future.
Absolutely. Thank you so much for inviting me, Kenny, and thank you, Ben, for your input as well. I really look forward to meeting you both at the annual meeting, in October.
Thank you for joining today's podcast. For more information about the speakers or the topics, please go to ohioacc.org.